I would like to thank the organizers of the committee. This is a beautiful organization. I hope it will be repeated in the future. Individualized treatment, more specifically, individualized treatment, individualized medicine, of course, you know, involves the diet, the living conditions. However, individualized treatment actually addresses the issue of cases refractory to treatment. In the cases which are refractory to treatment, we have to introduce individualized solutions. Individualized treatment requires to have a knowledge about the information about the genetic structure of the person, in order to foreshadow the treatment response of the individual. Genetic profiling in neuropsychiatry is a very common practice. It's no longer a dream of the past. It is a practice that is being reflected onto our daily routine. Therapeutic drug plasma levels, studies conducted in these directions, genetic polymorphisms being used in the early diagnosis help us. We can foresee whether our drugs will be effective in the patient or not using these notions. In pharmaceutical treatment, the classical approach is trial and error. You prescribe the drug. If it doesn't work, then you try something else. You have a certain amount of time to lose. What is the alternative to the trial and error method? There is a method used, especially with the cancer cases. You have to have a protocol. You have to have a decision tree. In psychiatry, we have protocols. For example, psychotherapies are being conducted through protocols, or brain stimulation techniques are using protocols. However, with drug therapy, protocols and algorithms, although they are present, they are not clear. And the method of protocol and the foundation of protocols, clinical pharmacogenetics, I believe, will contribute a lot. Genetic profiling, genetic prototyping, genetic polymorphisms, detection of the genetic polymorphisms, plasma level detection, liver enzymes, cytochrome enzymes can be investigated for the individual in order to understand the individualized response of the patient. In the refractory cases, these help us to understand the variances. I would like to talk about the instruments used in these investigations. These are instruments which are capable of detecting minute levels of drugs. Metabolites, drugs themselves can be assessed using these novel instruments. Plasma levels and therapeutic index range. What about it? Therapeutic index range, for example, in carbamazepine or BPA or lithium, you know that toxicity is a very important issue because the therapeutic window is so small. You have to be careful about the toxic dose. Maximal dose brings along maximal side effects. Therefore, in order to fine-tune the doses, you know, sometimes you prescribe elephant dose to your patients and you do not get any response anyway. We have to monitor our patients' plasma levels in terms of the drugs that we are using. If you are suspecting a difficulty in response in children, in the elderly patients, plasma level detection is very important. In preventing relapses, in liver disorders, plasma levels are very important. Plasma drug levels are very important. In refractory cases where you are living relapses, even though your drug levels are satisfactory, then you can go for further investigations. Why are these important? When the patient receives the drug, how many hours later can we look for the drug in the blood? You have to have an idea about it for every drug. There's a theory as follows: psychiatric patient, diagnosis, response, remission. The target of every psychiatrist is to apply this decision tree. However, mostly we are using trial and error. And there is a chaos in our daily routine. This is a case presentation. This is a schizophrenia patient. In this patient, various drugs have been used. There are many suicide attempts on behalf of the patient. When the patient's blood levels were monitored for the drug, the patient had benefited in terms of treatment. In this case, this is a genetic phenotype interaction. The genotype of the patient, the genetic structure of the patient, and gene expression and interaction with the environment causes mutations and such, causing the metabolism. Pharmacokinetics and the pharmacodynamics of the drug are very important. Those blood levels of a drug, citalopram, was studied in this publication, and blood levels were monitored. Another study for amisulpride. I have many slides and I have very limited time, that's why I'm going through them so fast. Dopamine D2-like receptor binding with amisulpride and its relationship with the plasma levels with PET scan, dose and binding. This is from Mainz University. It's a German study. Serotonin binding and peroxidine relationship between the two was addressed in this study. Condensation in the plasma is very variable between the patients. Plasma concentrations and brain concentrations are related. Plasma concentrations are related with the receptor affinities of the organism, and plasma concentrations reflect brain concentrations. Therapeutic drug blood level. Therapeutic drug monitoring investigation is conducted here. You see the studies here. How does a drug diffuse in the individual? Its therapeutic level increases. Trust in the drug is increased, and cost of the drug therapy becomes optimal. What about cost? I have to go through this very fast. Cost-benefit analysis was conducted for amitriptyline, pharmacokinetic dose, plus blood drug monitoring. 2.5 was the benefit-cost ratio. Plasma level monitorization prevented overuse and overdose. This was conducted in the 90s. A similar study. It has saved a vast amount of cost. These are, of course, American figures. Another study about citalopram. Therapeutic drug monitoring in psychiatry. A study. There are many studies conducted with tricyclic antidepressants. You see the TCAs, and their blood levels were monitored. Dose recommendation in comparison with random drug use. Therapeutic blood level monitorization was compared with random use. You see here, when the drug was monitored in the blood, you see the HAMD and global assessment differences in early phases, clinical decision making, plus drug blood monitorization has given the best results. Of course, the match between the two is beyond being perfect. However, the results suggest that pharmacotherapy optimization studies will be beneficial. We have a study we conduct in Canada. We sent our specimens to Canada. This was another study by venlafaxine. Drug plasma levels monitoring need to be analyzed very carefully in order to understand. You have to know the profile of the patient, the genetic profile of the patient. You have to have information about the genetic profile of the patient, and you have to interpret the results accordingly. This is another study for amisulpride. I'm sorry I have to go through this so fast. I have more important slides coming up. Baseline dose, blood withdrawal, reporting, and dose adjustment are the steps in drug blood level monitorization. This was a study from 2006. According to this procedure, the cost-benefit analysis was conducted. You see the match. These are the days after dose change. Drug blood level monitorization was conducted in the patients, and you see that the positive results were high. Another study from 2004. Pharmacokinetic problems. 41% between 0 to 3 days, 38% on the day of the changing dose. Clinical problems, 57%, no increase in dose, although the blood levels are very high. This is another publication on the subject. These are drugs and the plasma levels of the drugs in nanogram per milliliters. There are therapeutic ranges for every drug: olanzapine, quetiapine, thiopine, and level of recommendation. Based on the level, the profile of the patient is drawn. Treatment drug blood level monitorization, side effects, risk, intoxication, child, adolescent, relapse prevention. All of these areas benefit from treatment drug blood level monitorization. Clomipramine, fluvoxamine, drug plasma levels are very important and very beneficial. You see the literature here. What about decision making? With change of dose, I will try to summarize. What about the future? Early prediction of antipsychotic response in schizophrenia. Early foreshadowing is very important. Antipsychotic drug response, refractory cases, what about them? Clozapine, there are many studies conducted with clozapine. in refractory schizophrenia cases, use of clozapine and its toxic effect. It's very important. This is a case presentation. This is our case. This was a 20-year-old male patient. Lifestyle profile was as follows. He received schizophrenia diagnosis at the age of 16. He was treated in Switzerland for 2 years in a hospital. He received drugs for 3 months. He did not receive any benefit. He was refractory to antipsychotic drugs and ECT. We drew blood from him and sent it to Canada. And these are the drugs that the patient was using. You see that all the big antipsychotics were used by this patient. This is the results. These are the results for the case. Substrate and enzyme profile, genotype result and phenotype result, and enzyme activity. This patient, you see EM for extensive metabolizer, EM-DIM for extensive metabolizer diminished. As a result, our case for clozapine, he had very high cytochrome 1A2 activity, which might have been causing the clozapine treatment resistance. This suggests that in this patient, clozapine might not be the correct choice of drug. After Leponex, CYP1A2, he was a 1A, 1FLL carrier. He had a polymorphism and he was an ultra-metabolizer. You could give the clozapine to the patient, but the clozapine the patient metabolized the clozapine so fast, it was like giving him water. It was as if he was drinking water. The additional use of cigarettes was, of course, another issue you have to consider. You have to monitorize clozapine plasma concentrations if you want to use clozapine with this case. This was the report received from Canada. And using CYP1A2 inhibitor fluvoxamine at the dose of 50 milligrams per day, it would have been possible to decrease clozapine dose by 50%. The important issue is to monitor the plasma levels of clozapine. What should the dose be? Interpretation of the doctor is very important. Another study about risperidone. Risperidone is a prodrug and it's an atypic neuroleptic which is metabolized by CYP2D6 plus CYP3AD. Antipsychotic effects are caused by the metabolites. This patient was a poor metabolizer for risperidone. Therefore, in this patient, prodrugs or potent drugs need to be adjusted in terms of dose. This patient was not able to create adequate metabolites from the prodrugs in terms of risperidone. Therefore, the patient was not receiving any benefit at the dosages recommended. This patient went to Switzerland. We sent the report to his hospital in Switzerland, and we recommended that haloperidol would have been better for this patient. Again, use of risperidone and the information conveyed to the patient, and they had recommended paliperidone. As a result, this patient received recommendations because this patient was a poor metabolizer in 4 liver enzymes. And This information is very important for the patient because this information is vital for the patient, which he can benefit from throughout his life. You look at the genetic profile, you look at the pharmacogenetic profile, you look at 1A2, then it's not advisable to give any drug to this patient which uses this enzyme as a metabolizing route. It helps you in making your decisions. This is true for many different drugs as well, anticoagulants, for painkillers. If I am to go back to individualized treatment, genetic profiling is very important. This is another individualized personalized medicine application from Netherlands. Quantitative EEG and neuropsychological and neurophysiological checkup was performed in this center, and this center recommends individualized treatment after these checkup procedures. Similarly, magnetic stimulation treatment and the use of magnetic stimulation treatment. This is a form from our clinical pharmacogenetic laboratory. You can ask for the therapeutic drug blood level, or you can ask for the genetic profile. You need 20 days to receive the genetic profile. It can be conducted in Turkey as well. Prior to do that, you can monitor the patient through plasma levels of the drug. You have to have information about the plasma levels, and you have to have information about the administration time of the drug. We have developed the protocols, the standards, and interpretation of the data is very important. You see which enzyme metabolizes which drug. There are 4 cytochromes, importantly, inhibitors, stimulators. In this graphic, you see drug level, effective level, toxic level. Below are the days. Professor knows that you are beyond your time. Toxic levels, effective levels, you have to keep the drug in this level. What about the genetic profile? These are the enzymes and its relationship with the genetic. This is our instrument at our facility. This is our pharmacogenetics lab. Thank you.